to the Series 6 of Amplify Sickle Cell Voices, and we are discussing sickle cell testing and follow-up. And on this panel, I just want to thank the hosts for today, Dr. Tomia Austin. We also have Shanta Robertson. We've got our expert for today, Dr. Titilopi Fasipi, and we have Sam Bunya from Kenya. We've got Preeti from India, and Nameshi should be coming anytime soon. We also have Sharif, who should be coming anytime soon. So before we start, continue with the program today, I'm not on the panel today, but I'll just introduce Australian Sickle Cell Advocacy. As we've been doing, this is our Series 6. We've been doing this, plus we also had a French series. We opened our platform for us just to bring people together from all parts of the world for us to discuss any topic in sickle cell, and we thought, why not just bring, especially the people that came on our talks, weekly talks, sickle cell talks with Agnes. I just thought I can bring back most of the participants and bring in other people, and other people brought in other people. Before you knew it, was a group of over 40 people. So I just want to thank you, everybody who's come on board. Actually, before I go ahead, I just like to acknowledge the traditional owners of the land on which we speak. I pay my respects to the elders past, present, and emerging. So usually what I do, I give a presentation about Australian sickle cell advocacy. We are now in week 7 plus the French series. I won't do that now, but what I'll do today, I'll just tell you about something that we are working on. One of the things that we are working on, and that's we are bringing you next year. We are going to bring you the first ever sickle cell conference in Australia. We've never had a conference about sickle cell disease. We are doing this conference with the providers or the organizers of the blood conference, and through the Hematology Society of Australia and New Zealand. So we are doing this next year around this time, September 18th. And if you have time, please check out our Facebook, our website for the conference. So we have done our conference. We are going to have the conference in Adelaide. Adelaide is about an hour from Melbourne. It's going to be on the 18th of September, 2021. It's going to be at the Adelaide Convention Center. And our theme for the conference is Breaking the Barriers, a New Horizon. And we want people to continue talking about sickle cell. And we have some fantastic speakers. So I'll just show you the speakers who will be coming to this conference. If COVID will be an issue, the conference is still going on virtually. So we have Professor Inusa Baba joining us, Professor Ikuta Nihara, Professor Isaac Odami. We've got scientists, Professor Merlin Crosley, Professor Lois Xu. We have Stephen Botieng. We have Yemi. Peter is one of our members here, somebody living with sickle cell disease. Mwewa is a caregiver in Australia. And we have supporting organization here in Australia. We've got Monica Ferry from Genetic Support Networks Victoria. We have Professor Andrew Perkins, who's a scientist also in Australia. We have Dr. Anthea Greenway, hematologist, who was my daughter's hematologist. We've got Ms. Biba Tinga from Canada. Dr. Kylie Mason is an adult hematologist here in Australia. Dr. Pascal Barbara is a pediatric hematologist here in Australia. Nicole Mills is the Chief Executive Officer for Rare Voices Australia. Professor Joy Ho. We have Heather from Syndromes Without a Name, and we've got Mr. John James from Sickle Cell UK. We're still accepting other speakers. It's going to be a full day, and we've got so many things planned up. So we're still in the planning phase. So we are asking everyone, please check out our website. It's askaconf.org, and just see what you can do in terms of joining us. It's either going to be face-to-face. Hopefully the COVID would have finished by then, but it's going to be virtually if the COVID will be an issue. And with that, we are fundraising because of the same thing. We if you've seen what I posted, I think the other day, we've started a fundraising venture specifically for this conference. And one of the things that we are doing is just doing something for fun. If you've got time, we should also check out our website. It's askupkeepfit.com. Join us from December. We'll be doing just light exercises Monday, Wednesday, and Fridays, and for a good cause. And this is for the conference specifically next year. So join us, askupkeepfit.risely.com, and that's the website for us to do fundraising event, but I'll share it across all social media platforms. I don't want to take much of the time today. It's a very important topic for me. I've had this discussion before with Dr. Tomia Austin. Sickle cell testing, I've told my story over and over again. I had a very bad reaction when I had my daughter. I had, because of the sickle cell trait. And I think you guys are going to discuss that. So again, I apologize because we started off a bit late, but I'll hand over to the host for today, who are going to tell you more about the topic and the subtopics and the questions and everybody joining us today. So I'll hand over to Dr. Tomia and Shanta, and I'll make Dr. Tomia Austin as a co-host in case you need to just drive something, and I'll come back when you guys finish, and I'll just hide myself. Thank you so much, everybody, for joining us again. And I'll hand over to you, Dr. Austin. Thank you.
Thank you, Agnes. Good morning from the United States. It is approximately 6:30 a.m. for us here. And I would like to also say good morning to my co-host, our co-host, Shanta Robertson.
Yes, good morning, good morning. Welcome everyone. And it's quite early here, and I'm very happy to be awake and joining everyone.
We are definitely very happy on behalf of the As One Foundation, where our mission is to empower families globally, delivering life-saving sickle cell education. This falls right into our wheelhouse, and globally, the times are different, and we understand it's after 9 p.m. in Melbourne. We have Sweden on the line, India on the line. So this is what global reach is all about. Finding us wherever we are, whatever the time is, making it work, regardless to COVID-19, regardless to whatever limitations there are. This is a very important subject matter, and we are so grateful for the Australian Sickle Cell Initiative that has put this series together to amplify sickle cell disease voice. And our subject area today is sickle cell testing and follow-up. With that, Shanta, would you like to invite our panelists to introduce themselves?
Yes, and I just wanted to say on behalf of the Maryland Sickle Cell Disease Association, I also look forward to this opportunity to share more awareness. That is a part of our mission as an organization, to share awareness about sickle cell disease so that we can continue to move things forward and get to a cure, which is what we all, I know at the end of the day, strive for. So without further ado, I'd like to please ask our guests to introduce themselves and just share a little bit of information about yourselves. And if you would like to start, Dr. Fusipi, then we can just continue with our panelists.
Hello, my name is Dr. Titi Fashipa. I am a pediatric hematologist working in Houston, Texas. And I also am a sickle cell warrior myself, and very passionate about spreading awareness for sickle cell disease and trait. So thank you for having me here today.
Thank you. Sam?
Yes, good morning, good afternoon, good evening to you all. My name is Sam Bunyam. I'm from Kenya, currently based in Sweden. And actually my background is biomedical science, although I have looked into health systems management and also global health in general over the past couple of years. Got experience of about 10 years in the biomedical sphere. And also my current role is in advocacy relations, looking at working closely with stakeholders and partners, ministries of health, everyone dealing with sickle cell disease and hemophilia. But since we're talking about sickle cell, my role is actually just to bring people together and see how best to have sustainable programs and put concerted efforts to be able to improve the lives of people living with sickle cell. So thank you for this opportunity, and looking forward to add more value to this discussion.
Thank you. Preeti? You're muted. There we go.
Unmute yourself.
Unmute you. Yeah, there we go.
Sorry. Thank you. Good morning, good evening, and good afternoon. Where I'm from India. My name is Preeti Chende and Nagrare. My sickle status is I'm sickle cell trait. I'm a parent activist. I'm a mother of 16 years, asymptomatic girl warrior. Had a second child with no sickle cell gene by prenatal diagnosis, who is now 11 years old. I am a president of parent activist group, the Sickle Cell Parent Association in India, the executive member of National Alliance of Sickle Cell Organization, professionally working as laboratory technologist in Government Medical College, Nagpur, India, and working from 12 years with the Sickle Cell Society of India, Nagpur, and as a member. And I'm thankful to late Mr. Sampatji Ramteke, who is my inspiration for fighting against government for betterment of sickle cell anemia. People from 30 years he fought with government and he got awarded for that from the Indian government. My aim is to eradicate sickle cell gene, not only from India, from world. Nobody should go through this genetic condition. Our motto is same, to raise our voice. For that, unity is very important. On global platform is necessary for that, and you give us that opportunity. And by using technology, by using social media, we are connecting with each other and share our stories and unite and raise our voice to make world free from sickle cell. One voice for sickle cell. Thank you very much, all of you. Thanks a lot. Over to you, Shanta.
Thank you so much, Preeti. We appreciate that nice warm welcome. Sharif, do you like to give a little information about yourself, please, sir?
Good morning. My name is Sharif Tesovida. I am from Kampala, Uganda. I'm currently based in the United States, focusing on my doctoral studies in genetics. My background, I was the first executive director of Uganda Sickle Cell Rescue Foundation in Uganda. I now work as a board member for Uriel Owen Sickle Cell Association. I have sickle cell hospital, and I'm very passionate about sickle cell disease and sickle cell awareness. So I'm pleased to be here.
Great. It's great to have you. Great to have you. All righty. Would you like to start us off, Tamia?
I am interested because our topic is sickle cell testing and follow-up. I would like to hear from everyone just to get us started on their position regarding sickle cell testing and follow-up. Here is where you can tell us your experience, something of particular note for you, the challenges, and any good news as well. So Dr. Titi, please start us.
Okay, there is so much to say. I'm going to try to highlight a few using my own story. I was born in Nigeria, in Lagos, and at that time, well, not much, I will say at that time, there was definitely no sickle cell testing. My parents didn't know I had sickle cell disease until I was about 1 year old. And they couldn't understand why I would be crying sometimes, you know, what was wrong with me, why I was experiencing pain. And so they found out my diagnosis after I had been sick multiple times. Fast forward, we moved to the United States first when I was 3, and my mom rushed me to the closest, children's hospital sickle cell program at the time. And this was actually first in Tennessee. And she hoped that maybe being in the United States, they would have more things to offer. But in the 1980s, there wasn't that much going on with sickle cell disease in the United States. And so they really didn't give her any additional information. So then our family moved to Texas, and that's just kind of how my life was. I would see doctors, but I was always almost a little behind in regards to understanding advances for sickle cell disease. Now, I didn't know this at the time, but at the time, the United States had a very speckled pattern in regards to sickle cell gene testing, or even thalassemia and some other red blood cell disorders, what they call hemoglobinopathies, so disorders of hemoglobin. And the state I moved to, Texas, they started testing babies for sickle cell in 1983. But not every state in the United States started testing for sickle cell at the same time. In fact, sadly, it sounds shocking. The last state started testing in like 2003. So right in our near period. And so for a span of, so I think from the 1970s, the first state, all the way to the 2000s, that was how long it took for all 50 states to start sickle cell testing. And I'll tell you, the technology to test for sickle cell was available in the late 1960s. So if you see that gap, and again, America, United States, we all consider it a first, a high resource setting. There was a huge gap in regards to getting awareness about this disease and the importance of testing while young. So why is it important? Why does it need to be on the newborn screen, or why does it need to be detected in infancy? I shared a little bit about my story, but my story is one of millions of people who never knew they had the disease until they had their first problem. Now, sometimes that first problem is pain, but unfortunately for children, overwhelmingly, that first problem is a serious infection, serious enough to kill. In fact, in Africa today, sub-Saharan Africa, where the large majority of people with sickle cell disease live, you cannot promise children, living past their 5th birthdays at times because of sickle cell. After the United States started testing babies for sickle cell, we started noticing a change in the mortality, in the death rates. Just like Africa, children were dying very young because of infection. But then when we realized the importance of catching them when they're young, and through certain research studies that showed penicillin can try to protect them from infection, the lifespan of children just continued to grow. So from the 80s to the 90s to the 2000s, you just started seeing children with sickle cell living longer because they were being caught earlier and their families were able to do intervention. So that's part one, the disease. And I'm only going to speak briefly because it sounds like there's many experts here about trait. So what about knowing your status? I heard somebody use the word status. In Nigeria, it's common for us to go around saying, are you SS? Are you AS? Like we know our status. It became a thing. However, that doesn't happen in the United States. You won't really hear a lot of people saying they know their status when it comes to sickle cell disease. And sometimes when they think they know their status, they might be wrong. And this is everywhere around the world, I've noticed. A lot of people will insist they're one thing, but then when you test them, there's something else. So I feel like this is very important because of what Ms. Preeti mentioned, and I think several of you had mentioned about your future generation. Our genes impact our future. Our genes impact our children, our genes impact our future. And that's not to, trust me, this is not to put guilt on any family because I don't believe in that. It's more about the education piece and just having that comfort that you can do the best you can for your child at all times. Having awareness of your genes gives you some of that power. So I think I'm going to stop there and see, I'm sure other people can add to this conversation.
Thank you so much. Please, is there someone that is, well, before we continue, I definitely want to hear everyone's response. We have Nomesh joining us. Nomish, will you please introduce yourself and briefly just tell us a short portion of your story, especially as it relates to our topic today, sickle cell testing and follow-up.
Yeah, thank you. Thank you, everyone, and good evening to all. And my pleasure to Alaska Sickle Cell Alliance Advocacy. My name is Nomesh Kumar Verma, and I am a sickle cell warrior. I am president of Disabled People Organization. Since I am also a warrior, and because of sickle, I am having multiple disabilities. I work for awareness programs so that this disease won't be passed on to other kids like me. And sorry to say, my native language is Hindi. To interpreter is Preeti Sande, Maharashtra. So I will show that not in comfortable in English. So please, I am speaking Hindi.
He is asking to speak in English, speaking in Hindi.
Sure, absolutely. I think there's a little bit of internet, maybe.
Maharashtra.
There we go.
Romesh, आप हिंदी में बोलो.
Thank you, Nomish. Now, before we moved on, I wanted to thank you so much, Nomish. We're happy that you were able to make the webinar and happy to have you on board. I just wanted to ask Dr. Titi a quick question before we move on to for others to share their experience with trait testing. How big of an impact, or what do you think the significance of knowing your genotype, SS, SC, S beta thal, what impact do you think that has on the care that you should expect to receive, or the amount of intervention, if you will? What bearing does your genotype have on that? I ask because a little bit of my background, we have 3 sons, 2 of whom have sickle cell disease, sickle beta thal plus, and they are in their early 20s. And we were told when they were born that they shouldn't really have a lot of issues because of their genotype status. And for one of our sons, we have not found that to be the case. He has had quite a few crises. So how would you speak to that, the relevance of your genotype and the type of care that you should receive?
Oh, how should I answer this question? I'm going to answer it truthfully, and that means the answer is painful. Okay. I think everybody on this call, and probably the majority, if not all of the people listening, understand that sickle cell disease has been neglected by society. Even when we come from societies where it affects a large number of people. And so the reason why I'm already angry by what she's saying, because that shouldn't have happened. Mm-hmm. But it happened because of that knowledge piece. Even from the medical community, sickle cell was not as high priority, so people did not know enough about it. There's just so many layers to what you said, Miss Shanta. It's almost like, one, your children are younger than me, probably by decades, I'm assuming.
Not by much.
Decades and decades younger. And they were told some misinformation, right? So first of all, I don't think there's anything called good sickle cell, by the way. Whether you have sickle cell SC subtype, S beta thalassemia subtype, SE, whatever you want to say, for the majority of people with sickle cell disease, it is a disease. It is a disease. It comes in different flavors. It affects us differently, but it is a disease. And so you have to think of it as a chronic disease. We may do different things to achieve the best health for ourselves. And some people may have more complications than others. But if you already give families a confusing picture by saying, oh, nothing bad's going to happen to your child, everything's going to be good, or everything's going to be bad and your child's going to die by the age of 18, right? Because it can go both ways. You can get misinformation that gives you maybe unrealistic expectations, as well as sad, scary expectations. And if you told a mother that their child was going to die at the age of 18, what do you think that mother's going to do? They're going to put their kid in a bubble. That child is not going to have a life. Their child's life is marked by expectation of death. On the other hand, if you tell a family that, oh yeah, your kid's fine, barely has sickle cell disease, just a dabble, just a sprinkle of sickle cell, and that child wants to play sports, or let's say it's a female child, she's ready to have children, and she's like, okay, I don't really, she may not tell her doctor she has it. I know a majority of people, especially when they have SC and S beta plus thalassemia, many of them don't realize they have sickle cell disease until their adulthood and they have their first major problem. And it can be severe, And so on one hand, I'm always the most optimistic person. I don't want anybody with sickle cell disease to have complications, but I'm also not going to ignore the fact that it's a disease, okay? So understanding your genotype, I think, is important when it's coming to talking about having your future children. But whether your genotype, no matter what the alphabet letters, whatever letters it is, I want you to know it's a chronic disease that needs good care. You need to have the best quality of life for yourself. Same thing with the trait. You don't want to ignore the fact that you are a carrier. You have genes that might implicate your health and your children's health. And so, yeah, I'm frustrated because I wish there was more. I will say that now for a baby born, again, it still has to be ideal conditions. You have to have a doctor that really understands sickle cell. But if you have a child that's born and they know the genotype and you go to a doctor that actually understands sickle cell, you will get a much better picture of expectations for your child in today's time point in some places. So I don't know if that fully answered the question.
It did, and thank you. Yeah, no, that was great, and thank you. I didn't want to put us off track too much with everyone having an opportunity to share the response, but I thought it was important to really kind of break down that whole, genotype myth. That you have more, better cases as far as potential outcomes depending on genotype. So thank you so much for that response.
Exactly.
Thank you. So we'll just continue the questioning. Sam, would you like to go next and just sharing information about testing?
Sure. Yeah, thanks a lot. Actually, I think Dr. Titi has made it a bit easier to loosen up the conversation because she's put it in a very good way in terms of explaining, of course, the disease, the experiences about when to test, how to test, and the follow-up issues that may arise, and the responsibility that everyone plays a key role in terms of testing and follow-up. I'll put it in a perspective of a programmatic perspective because I've had experiences with managing a sickle cell program in Kenya, which is supported by various stakeholders and partners. And this is something that probably is replicated in different countries in Africa or even in India, and also looking at some of the challenges that are being faced over there. One of the things, of course, is creation of awareness. Of course, there's awareness of what the disease is. There is testing. Is there availability of the testing? And also looking at what tests are available at that particular time. Are healthcare professionals also aware that these tests are available in different facilities and also in the communities? Are they aware that these testing is also available in the facilities, even close by. The simple test, Sickling Test, which is something that most of you know about, is the simplest test that can be found for just a simple diagnosis for sickle cell disease, or even, but of course, we don't know about sickle cell trait because it's a sickling test. But of course, availability of that has also been a big problem in certain parts of different rural areas, etc. And it all goes down to one thing, of course, is creation of awareness, as I've mentioned, in the communities. People are aware about testing, and also genotype status. When you start telling people what is SS, SE, AS, they don't know anything about that. So it still goes back to the ground rules, grassroots. What is sickle cell disease and what is sickle cell trait? So creation of awareness is still a key challenge. Despite even the fact that these platforms for testing are available, and people have gone for testing, for example, where in the facilities, or a mother would go to the clinic and present a baby who has, the swollen hands and feet, and the healthcare professional says, well, we think it's sickle cell, maybe let's do a test and confirm. And then after that, they do the test, and then what happens? The follow-up issue has been that, is there availability of healthcare professionals who are also equipped to have the knowledge to take care of children who have sickle cell, and also for the ones who have been confirmed to have trait, what would be the way forward for them? So it also still goes down to education and training, creation of awareness as well, so that people get to know that, there are consequences in terms of probabilities for people to get children who be, a percentage of them having sickle cell disease, if they're partnering with, people who have trait as well. So I think it's just more like education and training that still goes down on a programmatic perspective. Follow-up, of course, is key. And one of the things that I've noticed in working in an environment where people are tested, and then is there a registry to show where these people are being tracked, where are they going, what are they doing in terms of their care, and also in terms of their follow-ups. Are they getting the appropriate medications, and so on and so forth. So there's quite a lot of loopholes and gaps which still needs to be filled in terms of this discussion. And how I'm sort of like looking at it is holistic in the sense that it all boils down to everyone playing their specific roles and working together and creating this seamless system where everyone is communicating with each other and being able to track and know what is going on with the person, especially from the day they are born. Newborn screening is one of the best things that have ever happened. But are there capacities for that to happen in certain parts of the world? Not so much. And even if so, even if it is there, is it reaching out to everybody? Are there policies for the governments to enforce newborn screening? It still all goes back to some of these things of data, information. People still get to understand, try to understand where these people, like we know of them, we see them everywhere, but where are they? What are they doing? So patient organization groups also play a big role in advocating for people to be tested, and also in terms of, well, we've tested people, what happens after? So their follow-up as well. So that communication, that link to speak as one voice is something that still has a big problem. And looking at even this conversation is great because it brings everyone together and start thinking of ways of closing those gaps and having that discussion be on a broader perspective. So, I mean, I'm looking at it on a programmatic perspective, on a policy perspective, and all those things that brings people together and close those gaps. So yeah, that's my approach to it.
This is really great, and to bring to your words, we've all come together, Uganda, India, Sweden, the US, Australia, to hear these perspectives. We actually have Sharifu, did I say that correctly?
Yes, that's fine. That's pretty fine. Yes, you did say it right.
I
For the
want to say
good try.
not
You
just
have said
fine.
it right. Yes, you have said it pretty fine. Yes.
You, in answering your question, please tell us specifically your experience in setting up a testing program in Uganda. What are what did you experience? Did you experience challenges? How is that going?
So I'll start by saying from a community perspective, because in Uganda, I think for the majority of the time, it wasn't until 2017 that we got a local name in one of the main languages for sickle cell. So you would go to a community and say, you know what, we are here to tell you about sickle cell. It's a genetic disease. We have to know your status and be able to make an informed decision. And the next thing people would ask you is, what's really sickle cell? I mean, how do I know that I have it in my blood? Because I'm not sick. I don't know anything about this. And how do I tell that I actually have sickle cell? So we had, I think, when we started our awareness, our advocacy initiatives in 2013, for the majority of that year, we had an issue in trying to convince people in terms of trying to show, you know what, they were always saying, okay, you have told me about this, but I'm not really sick. How do I even know that I even have it? How do I even know that it's in my family? How does it come close to me? Because in terms of sickle cell screening, there wasn't really an available platform for people to be able to screen. So my background is in biomedical science. So I had been trained as a biomedical scientist, but my full-time job was I was a sickle cell advocate. I was running a non-profit, and I'm like, this is something that we could do, because online there are cheap testing kits that we could use, that we could be able to employ, and for people to be able to test. So in 2017, we decided to do a pilot. We had a big sickle cell event, our sickle cell conference, and said, you know what, at this event, let's see, can we be able to test people as we go on with the sickle cell education? And if we can be able to test, how many people can we be able to test? So on that event, we actually were able to screen over 500 people. So that was a big shock at us. Like, you know what, it is very possible that we can have a community event and screen as many people as 500 people on this first event as just our trial. It's just a way of being able to try and pilot out if sickle cell screening can actually be done. But the key aspect was, okay, if you want to be able to screen, what are we going to use? Because if you're looking at community screening, you must talk about accessibility. You must talk about the turnaround time, because if you come and find me in my wherever I am and take off my test, you won't tell me, yeah, we shall go back to the city and run your lab results and send you results in about 3 days. It then beats the purpose of why you're actually doing it, because you won't have you're not able to have a way of following up these people. So the key issues we were focusing on is, one, being able to find a testing kit that's affordable, that people can be able to use wherever they are. It has to be a point of care test where you don't have to have so much expertise, but if you have some trained people, healthcare workers, they should be able to use this test. But the other most important thing was the turnaround time. It should be able to give you good turnaround time, that if I take off the test now, I should be able to have my results in 5 minutes, 10 minutes, 20 minutes. So I can be able to wait, and maybe as I speak to the genetic counselor, as my result is being done, then you are serving me the purpose. And that's what exactly we done. That's exactly what we did. We were able to find cheap kits that were able to do sickle cell test trait testing. So it was a way to start, because people didn't have that ability to be able to test anything. And we saw from the success that we had, I think our next big sickle cell conference in 2015, we were able to screen over 1,500 people on one day, on the World Sickle Cell Day. And then from the successes of that, the Ministry of Health was able to adopt this initiative and see it as something that can be done. And sickle cell entities now across Uganda are really doing this on all their community events. They do sickle cell screening at their community events. But the key aspect were in terms of seeing how people can be able to understand, because now on the advocacy perspective, where somebody you tell them, you know what, we're here to tell you about sickle cell. Like, what's sickle cell? You explain to them it's a genetic disease. You may not know that you carry the gene. How do I find out? We just take off your test here within 5 minutes. We'll have your results. Somebody is more willing to sit down and listen listen and say, okay, well, 5 minutes is fine. Let me listen to what you're saying, and I will be glad to see what happens. And the biggest reality is because, for example, Uganda has the 5th highest sickle cell burden in Africa. By that, we have 13.5% of our population having sickle cell trait. So this means every 1 in 7 people actually has a high likelihood of having sickle cell trait. So the majority of the people you go and find on these community events and screen them in them, when they're in the markets, when you find them at school, wherever you find them, would be shocked to say, oh my goodness, I have trait. Oh, so what does this mean? I mean, am I sick? Does it mean what impact does it have in my life? But the ability that you see how having an affordable kit that gives you good turnaround time, that someone doesn't have to go through the inconvenience of saying it'll take a number of days for me to get my results. And then we find that advocacy initiatives have been more successful, because then I'm not only hearing about sickle cell, but I take the test and actually know my genotype. And then now I'm more obliged to have more thought on the test that I've done, or whatever information I have had, given the results that I've had from my test. So that's one of the key issues we were looking at in Uganda, and this program has been pretty successful. I think today, as I speak, we have reached out over 100,000 people have been screened across Uganda, and the program is growing because every now and then, every non-government organization every non-government organization, whoever is running advocacy, is now trying to adopt community sickle cell screening as a key thing. And that's one thing I'm very proud of as a sickle cell advocate. That's one thing that I was able to do in my community to bring about change. So I think that's from my perspective. But the key other thing, just to wrap up, the follow-up is very, very, very essential. What happens when somebody has been tested, especially for those who we find to have trait, or even when we talk about now, because I think now Uganda, I think for the past 2 or 3 years, we are trying to have a newborn screening program, but the key issue still has been the comprehensive follow-up. It's not really there. I mean, even if the parent is willing to have the blood sample drawn from their baby, to wait for a week or 2 or a month to get their results, we often lose people to follow up after that. So that's where the key questions should be coming in. Testing is good, but what happens in terms of the follow-up? So we need to look at these things both ways, to test and then to follow up. So that's my perspective.
Absolutely.
Thank you.
Thank you so much, Sharif. That's excellent information. Thank you so much. And you make some excellent points. Priti, if we could have you to share your experience with the same question, describing universal screening methods, please.
You're still muted. Okay.
Thank you, Shanta. Universal screening for sickle cell disease and sickle cell trait. In India, there is a burden of sickle cell disease. There are 1.4 million sickle cell patients and 18 million sickle cell traits. To reduce this burden, the sickle cell screening program should be there. The carriers of sickle cell disease are asymptomatic. So they are not aware of that having sickle cell mutation in their hemoglobin or gene. They live normally and can do everything, every normal activity, but they will give birth to a sickle cell disease unknowingly. Therefore, there is a need of universal screening. In olden days, the main region for sickle cell in India are tribal regions like Gujarat, Chhattisgarh, Maharashtra, and Odisha. But now, the people are migrating for their livelihood from one region to another region in India. Therefore, they found all over India and in all communities. So the testing of sickle cell genotype should be mandatory for adolescent antenatal women and their husbands. The universal screening programs which are running in India, that are screening for adolescent, premarital and preconceptional screening, antenatal screening, and cascade screening. In adolescent, universal screening for adolescents to schools, colleges, it is easy to reach out to the adolescents, to school and colleges. There is high acceptance rate with retention of information among students when backed by intent. The education programs including lectures in schools and colleges before screening. That is very important. The counseling is very important before screening and after screening. To approach health in removing stigma due to applicability to all students, growing into adulthood with knowledge of career status, provide time to adapt this information to choose the partner for marriage. In India, there is a good experience of adolescent screening program in government schools and colleges. It gives positive result with high acceptance rate and retention of information by the student. That is very important. So after that, when they go for marriage, there is a premarital screening. So for that screening to be offered those individuals or couples who seek to as social norms vary from community to community, family to family, and it might be welcomed by some, but not by others. So through the approach, present both options to the carrier, that is not going ahead with marriage, or option for prenatal diagnosis. Later in each of the pregnancy, the premarital screening is in India population is still considered as controversial. So they choose first option, become a delicate issue. At the stage will depend on family. It is depend on families whether they accept it or not. The couple level of emotional bonding. If they are emotionally bonded, they accept it. They accept the partner. If and religion, beliefs, and customs may have influence. Thirdly is the pre-conceptional screening. If anybody is going for conception, the screening to be offered to those individuals or couples who keep it with appropriate genetic counseling. Through most with option of prenatal diagnosis with termination of pregnancy, some with religious restriction, they don't terminate that. So that's why the birth of sickle cell disease takes place. So with some of the religious restrictions might find the option for adopting a child better than having own child with the sickle cell disease. And fourth is the antenatal screening program. The universal screening should be offered to all pregnant women during first trimester at all levels. As most pregnant women are likely to come in contact with health services, and update is expected to be high. The states providing it should back it with the prenatal diagnosis services, either through referral networks or by developing centers within the health centers, health systems. And at our place, the district hospitals, rural hospitals, and primary health centers have the screening programs for antenatal screening. And when they get screened and they had the sickle cell disease or sickle cell trait, the cascade screening should be there. Cascade means the siblings of them who are sickle cell disease or sickle cell trait. The family should be screened. The family members of patients and carriers should be screened. The cascade screening of family of detected carrier is an integral component of screening strategy protocols. So some families with an affected child may either unwilling to communicate this diagnosis to their extended family. They don't accept it. They don't like to discuss it. So we have to counsel them. Counseling is very, very important. And we have to convince them to get tested. And it is very necessary to counsel and screen them. And in my experience, I had an experience in my experience, the gynecologist is a key specialist for this. A gynecologist is plays a very important role, and he is a key specialist. He implementing the program in timely and effectively manner. If gynecologist should and should encourage people to get the cascade screening. So thank you very much. I hope you got the answer. Thank you.
Yes, thank you so much, Preeti. That was an awesome response. We appreciate sharing that you shared your knowledge and experience. Nomish, if we could, and I hope I pronounced your name correctly, apologies if I did not, but can you share your experience with universal testing, please, sir?
Yeah, thank you, ma'am. मैं हिंदी में बोल रहा हूँ, प्रीति दीदी ट्रांसलेट कर।
हाँ बोलिए।
तो मेरा पर्सनल एक्सपीरियंस है, मैं तो बचपन से सिकल सेल्स के दर्द से झेल रहा हूँ और इसके कारण मेरी जो तकलीफें हैं, मेरी पढ़ाई और काम जॉब कुछ नहीं हो पाता था। तो मैं धन्यवाद करता हूँ अपने इंडियन गवर्नमेंट का और अपने स्टेट गवर्नमेंट का, छत्तीसगढ़ गवर्नमेंट का, जिन्होंने सिकल सेल इंस्टीट्यूट यहाँ छत्तीसगढ़ में बनाया और उसके लिए फ्री टेस्टिंग और दवाइयाँ उपलब्ध कराई। प्रीति दीदी प्लीज।
हाँ, he diagnosed when he was 7, and from his childhood he is suffering. He is not studying well because of pain. He is not getting job, and sometimes he get half amount of salary because he couldn't attend school, or he couldn't attend job the days of job. So financially he financially he unable to stable, and he is very thankful to the Chhattisgarh government for they are providing the free medicine, and they are providing some benefits, government benefits for the sickle cell or the disabled people. So he is very thankful for that.
मुझे लगता है कि ये हमारी सरकार ने जो सिकल सेल मरीजों का, वॉरियर का जो दर्द को समझा है और इसके लिए काम कर रहे हैं, और इसके लिए हर एक डिस्ट्रिक्ट में कैंप लगाकर अवेयरनेस काम कर रहे हैं, और एएस पैटर्न और एएसएस पैटर्न दोनों के लिए जागरूकता कार्यक्रम कर रहे हैं, उनको दवाइयाँ प्रोवाइड करा रही हैं। तो इसके वजह से हमारे जो आदिवासी क्षेत्र है, बहुल इलाके हैं, जो कि बीहड़ क्षेत्र है, जंगली क्षेत्र हैं, वहाँ के आदिवासियों को दवाइयाँ उपलब्ध नहीं हो पाती थी, जिसके कारण बहुत सारी तकलीफें होती है, और वहाँ के लोग जो सिकल सेल के कारण डेथ होती थी, वो अभी कुछ मृत्यु दर कम हुआ है।
हाँ, the government is aware of the sickle cell in tribal areas. Nomesh is from Chhattisgarh, that is the tribal area. There is availability of medicine for them, and government having awareness programs there, and the mortality rate decreases there because of the action of government they are providing medicine and doing awareness. So he is very thankful and he is very happy for that. Okay.
या थैंक यू। और इस प्रकार अभी छत्तीसगढ़ में अभी अवेयरनेस की बहुत ज्यादा कमी है, जागरूकता नहीं है लोगों में। जैसे 18+ 18+ एज लड़का या लड़की, गर्ल एंड बॉय, तो यहाँ छुपाते हैं। सिकल सेल अगर पॉजिटिव आता है तो शादी में, मैरिज में उनको तकलीफें होती है करके लोग बताते नहीं है, और इस कारण से अभी हमारे छत्तीसगढ़ में और पूरे इंडिया में कंफर्म डेटा कलेक्ट नहीं हो पाता है। लोग तो यहाँ टेस्ट करा रहे हैं, स्क्रीनिंग हो रही है, लेकिन जब तक लोग अपने से खुद से आगे नहीं आएंगे, इसके बारे में बात नहीं करेंगे, तब तक मुझे नहीं लगता कि गवर्नमेंट का और ये जो काम है स्क्रीनिंग के लिए वो सक्सेस हो पाएगा। इसमें हम सबको जिम्मेदारी उठानी पड़ेगी और हर एक वॉरियर को, हर एक सिकल सेल पेशेंट को, उनको पेरेंट्स को ये जिम्मेदारी समझनी होगी और इसके लिए बात करनी होगी, तभी कहीं जाके हम आगे सफलता पा सकते हैं। दीदी,
Government is taking awareness, but people are not aware yet there. So they are hiding their statistical status there. When they went for go for a marriage, they hide their status, and that's because of that the newborn are newborn babies are there. So people should come forward for that. People should come forward and get screened. That awareness is not there till now. So everybody should come and get tested. That is the Nomesh. Everybody should come and get tested.
इसके लिए जब तक लोग अपने से अवेयरनेस नहीं होंगे, तब तक लोग जब तक खुद से जागरूक नहीं होंगे, तब तक ये सिकल सेल का प्रोजेक्ट चलता रहेगा और सालों साल चलेगा, लेकिन कभी इसको हम रोक नहीं पाएंगे।
So please, he is requesting to people to come forward and get tested and aware of it, and to make India free from sickle cell genes, and there should be a registry for registry or data for the of sickle cell patients and sickle cell trait, so we can go forward for that.
Thank you so much, Nomish. That is I think that's an incredible goal that we all should probably strive for. To me, I think you had some a parting question before we wrap up in about 15 minutes or so.
Yeah, this has just been amazing, and I honestly feel like we could go for the rest of the day. I don't know if everyone on the live can look at all of the faces, but I'm watching our panelists nod and shake their heads left and right in just some reacting. I particularly had a reaction to, I believe you said, Preeti, 1.8 million with disease and 18 million with trait. So I'm just really curious how it even can be hidden with the prevalence in that way. And I certainly echo the what Nomesh says, which is, we need the testing, we need awareness, we need people to understand that this is not something to hide. It must be, talked about. I know our dear friends in Canada, they do have a universal screening program. However, they do not make the sickle cell trait warriors, as we call them, aware. That is not distributed by letter or by notification. They only notify the sickle cell patients. And again, to Nomesh's point, to a lot of the points I've heard today, sickle cell trait people make sickle cell babies, and a sickle cell person will guaranteed make a sickle cell trait baby. So you need the conversations to overlap and intertwine and so on. So that was really a reaction more than anything to your statement, Preeti and Nomesh. Thank you. We do have to wrap at this point. So Shanta, we have a final question for each of you that we ask that you answer. Try very diligently to answer within less than 2 minutes each.
Yes, and so we just want to know, just moving forward, what do we do? Just straightforward. How do we get this done, and what should be some next steps that we all should look to in taking action to make sure that there is universal trait testing and that everyone knows their status, right? And we'll start back again with you, Dr. TT.
Okay, so the speakers on this panel kind of highlighted many of the areas of gaps when it comes to when is the best time to know your status. And I probably see two time periods. You know, sometime when you're a baby and then sometime when you're a young adult, but I would not say necessarily wait till premarital. I agree with Preeti. I think premarital, to me, it's more about, if you're in love with somebody, you're in love with somebody, right? So it's more about discussion about your future and maybe children. But I do think young adults, just because of the lack of awareness and education, I do agree that there should be some version of testing for them, whether we say high school or a place where it can be easily done universally. So universal is a very high goal to strive for, but it starts with some small steps. It sounds as if in certain areas we are successful maybe with the children and infants, but it looks like we have a lot of work to do when it comes to the larger populations. So it's going to take a lot of work. I think advocacy is probably the main key ingredient here.
Beautiful. Thank you so much, Dr. TT. Sam, some last parting thoughts?
Yeah, I think it's been an interesting discussion just to hear everybody's standpoint, and I guess it's given it a holistic way. I think this is the main word for me is holistic, and being able to leverage on some of the technologies, the challenges that we're facing. There's no registry. Data management is also a big problem. Looking at the gaps with community health workers not even having information to educate and train the communities. Of course, we as a people have a responsibility to also learn a bit here and there, and also share, because sometimes in the families that they are affected or they know people who are traits, they keep it to themselves. So, having that information to be put out there also makes a big difference. So people need to speak out a bit more, and be given the chance to speak. Also, it's an up, down, top, down, down, up approach, where the government also needs to step in and assist and support, and the communities at the ground also need to step up and support the people who are affected and the ones who are traits, and also for them to speak up, because I think also the discussion always has been the person living with sickle cell, but the person also living with trait needs to be given a voice as well to share the experiences, whether it be they were looking for a spouse and then they find out the other person is a trait, then they couldn't be in a position to get or rather proceed with life and also have children because of the challenges that they're facing. What about them? The conversations start also even in the churches. Of course, we've mentioned about in the mosques, we've mentioned about religion, the cultural differences, the cultural issues that goes around with it. So, I mean, that conversation is quite a lot, looking at being honest, being transparent, being able to speak out and share experiences so that everybody gets to learn and understand what actually happens on the ground. I can say in Kenya right now, I'm part of a team working on a module for NCDs, especially for sickle cell, dealing with the community health workers, for them to be on, to have information and reach out to communities. And because they're the ones who are able to see the ones who are at risk and be the ones to also inform the communities and get for them to get to understand what sickle cell is and so on and so forth. Healthcare professionals have a role to play when it comes to follow-up as well. The government has a role to play to ensure that capacity is there, testing platforms are there, etc. so everyone has a role to play. And in terms of the follow-up aspect is just to ensure that they get the appropriate care, and also for the ones who have sickle cell trait, which everyone forgets about, they also need to be given a platform to speak out a bit more and also share the experiences. So, I mean, looking at it holistically, the connections, the conversations need to still continue, play all the roles as advocates to each specific area and be able to speak as one and continue having these conversations. And I guess it's actually getting better over the years. We didn't have this, let's say 2-3 years back or 5 years back, but look at us. Right. We're sitting here from different countries of the world. We're discussing.
That's
about
amazing. Absolutely amazing. Yeah.
Happening, you know, people from different parts, global organizations speaking as one. Why don't we have one big community in the world speaking about it, meeting in one central place or even virtually one central place, and be able to
I think we are definitely doing that. Absolutely. Thank you so much, Sam. We appreciate that. Pretty, if I could get some parting words from you and some goals as far as universal testing and what should we do next? You're muted. You're muted, yeah.
Sorry, every time
No worries.
muted. Sorry. For universal testing, the objective should be there. For screening, screening programs should be there. We have to pick up carriers in the community. We have to have genetic counseling for who are at the risk of couples, and remove the ethnic fears towards carriers. Who are carriers, they have the ethnic fears, so we have to remove them by counseling and try to implement the Cyprus model here in India also, and it gives the contribution to the social structure. The social structure is well, then the country builds that. The social structure builds the country. So some problems are there in setting up of screening programs. So if the test is very costly, so it affects the testing. If it is because for testing there should be a manpower. The cost of the test should be less, or mass program should be there. So
thank you.
The financial burden should not be on the patient's family. If they are going for a test and testing is having a high cost, so they couldn't afford it. So the cost should be less for testing, so they can do testing happily.
Absolutely.
Okay, and
thank you.
The mass screening should be there. For the mass screening, oh, hello.
We can hear you. Yes.
Oh.
Can you hear us still? Can you hear me? We can hear you.
Okay. The manpower should be trained. If there is a setup of the screening testing laboratory, a sickle cell testing laboratory, the manpower should be trained there. Okay, and laboratory staff should be there. Genetic counselor should be there, because before and after testing there should be a genetic counseling. Absolutely. And counseling is very important. Well equipped screening test should be there, like glassware, and availability of kits should be there. If and chemical required, mainly solutions or buffers should be there for mass screening. In India, we go for a mass screening with solubility test, that is the tube test. In rural area, there is no the infrastructure for the laboratory, so we have to go with the go for a mass screening with the solubility test. So in remote areas, there is no electricity to keep the buffer in cold temperature. So cold baths and all the things needed, they should be available in remote area. So the screening, one drop screening test we use for the mass screening, that is solubility test. And after that, we went for a HB electrophoresis, HPLC, and the DNA-based molecular lab for the prenatal diagnosis. The setup in India for the prenatal diagnosis is in the cities, big cities, and at the remote area, there is no setup for the prenatal diagnosis. So we have to send the sample from the villages to the big cities, or we have to send up the patients or carriers to the big cities.
Thank you so
These
much,
are the limitations here.
Thank you so much for sharing such valuable information. We unfortunately, I can't believe we're running out of time, but unfortunately we have just 2 minutes, well, 1 minute now. But if Sharif, if you could give, and I apologize for this, but a very brief final thoughts on what to do, and then we will allow Nomish to have a few seconds, and then we'll wrap things up for today.
Thank you very much. It's been a pretty good session. Just to wrap up, one thing we should probably all be aware of, that all the nations that have been successful at universal screening have done it because they've had a policy backing. If you look at the US, if you look at all developed nations, screening has only been achieved because of the policy backing in place. So I think one of the key things we need to be championing as advocates, if you're going to get to the level of universal screening, is to make sure that we start having a dialogue or conversation about having policies in place that ensure or promote and be to support sickle cell screening. That's the only way we're going to be able to do it. So this is the onus on every advocate, wherever you are, to make sure that you're trying to engage the government in your the government and other entities in your areas to make sure that screening is in place, and other issues that will especially like follow up after screening. All those are things that need a policy backing. So my wrap-up comment: we need policy to support universal screening, and that's what we should be. That should be the biggest conversation now as you work to achieve universal screening for sickle cell. So thank you very much.
Thank you so much, Sharif. And Nomish, final thought?
Yeah, thank you, मैम. मैम, मैं यही आखिरी मैसेज ये देना चाहूँगा कि जब तक इतनी बड़ी जनसंख्या है हमारे देश की, भारत की, और ग्लोबल लेवल में अगर देखा जाए तो ये अगर सिकल सेल का अगर पेशेंट अगर निकलते हैं तो एक तो उसके जैसे पूरा देश ही बन जाए. तो इसके लिए एक बहुत अच्छी शुरुआत है ऑस्ट्रेलिया सिकल सेल एडवोकेसी के माध्यम से, और सभी स्टेट में, सभी देशों में, युगांडा है, घाना है, नाइजीरिया है, और हमारे इंडिया में, छत्तीसगढ़ में, पूरे सभी जगह से अगर ये शुरुआत होती है कि सिकल सेल को अगर खत्म करने का एक टारगेट रख के चलते हैं, तो इसके लिए आप सबकी सहयोग की जरूरत होगी, हमको गाइडेंस की जरूरत होगी, और ग्राउंड लेवल पे, जमीनी स्तर पे काम करने की बहुत ज्यादा जरूरत होगी, और इसके लिए गवर्नमेंट के लिए सहयोग की जरूरत होगी. गवर्नमेंट, प्रीति दीदी प्लीज.
As all know, India is a big country and having a population of very huge population over here. So it is good to having a start with you people all to eliminate the sickle cell. We need your cooperation and your guidance. So we will succeed definitely to eliminate the sickle cell from the world, not only from the India. Thank you.
Thank you. Thank you all so much. This has been absolutely informative, really, really amazing. Thank you so much to Shanta, the co-host, who's kept us in line for these 90 minutes as we approach, going over shortly. To each of our panelists, thank you for coming to us, braving the early morning, the late evening, whatever it is. Thank you to each one of you for your contribution, for your passion, for your information, and for raising the bar for us, instructing us, providing us a pathway forward. This is not the end. We have certainly made progress, and we do acknowledge that progress has been made, and so much more is needed. And each of us in our prospective little spaces are doing what we can. We appreciate our listeners, our watchers, those that will review this afterwards, to please lock into our organizations. Please support this event is powered by the Australian Sickle Cell Organization. So with that, I will turn it back over to our leader today. Agnes, thank you so much for this opportunity.
Today I want to add something for Tomia. Tomia, please. I like your campaign, what you having on Twitter, that is to test challenge. I like it very much. This is very grateful to have you here. And we are also going to start this kind of challenge in India also. So thank you, thanks a lot. Thanks Agnes, thanks Shanta, and thanks Tomia and all the panelists. Thank you very much.
Thank you, Agnes.
Okay, well, thank you so much. I can't believe we finished on time, even if we started off late. So take note, series 7. Thank you so much for everyone. This was a very, very important topic for everyone. As we know, we've talked about this for us in Australia as well. We don't have newborn screening. We don't have prenatal screening, mandatory prenatal screening or mandatory newborn screening. So every hospital does what they need to do. So that's one thing that we're advocating for. Natalie is on the panel as well. We are passionate about this. All of us have got a story. We didn't know that we carried the trait until our kids were born. Even the adults that are in the organization, most of them didn't know that they actually had the trait until they presented to ED with sickle cell disease. So I feel this is the number one thing that all the countries or the hospitals should be doing. But as we've said, it's very difficult depending on which country you're coming from, which resource countries, whether you're coming from developed country or less resource countries. But even here in Australia, because it's considered as a rare disease, we see that we don't have those facilities. So I just want to thank everyone who's managed to come on. I know it's very early in the US, Shanta, Sharif, and Tomia, thank you so much for coming on. And we owe you, Natalie, we owe these groups. So call us anytime if you feel for us to support in anything you're doing. And everybody on this panel, let's just be as one big family. You're all fighting the same enemy, which is sickle cell disease. So as per family, what we always do is those people that have got their cameras off, if you want to be part of the big family photo, you can turn them on. If you want to say one or two things, you can say something before we head off. Very, very, the standards have changed. Like we are on time today, despite starting late. So I just want to thank you, everyone. That's it. Natalie, if you've got a few words to our special guests.
No special words from me. In keeping with time, respecting that we've all gone well tonight. It's wonderful to see Shanta on the call again. Dr.
Great seeing you
Tomia
always,
as well.
Natalie.
Yes, nice seeing you. And everyone else, it's always a pleasure. So see you next time. Thank you.
Thank you.
Until the next time.
All right, I think we'll be wrapping up now. Looks like we don't have anybody wants to say anything before we close off? Well, it's a good one today. Thank you so much, everyone, and good night. We are back after next week on the 24th. We are back with another topic, which is, I think it's empowering sickle cell warriors. We have another group coming, so join us on the 24th, same time. And we've got the French session also coming back on the 31st of October, Natalie? 31st of October.
Yes, that's correct.
For the French session.
So October, we'll be tackling neonatal screening in French. So please feel free to invite all the French experts that you know. We'll be glad to have them. Thanks.
Thank you. Let's continue the conversation on Twitter, on Facebook, or our WhatsApp group. And thanks, everyone. Good night, everyone. Thank you.
Have a great one.
Thank
Thank you.
Bye.
Thank you.
Thank you very
Bye.
much. Thanks a
Thanks
lot.
so much.